Okay, so we're going to look at respiration, we're going to look at SaO2, and we're going to look at temperature just to finish off our stuff on vital signs. So in terms of respiration, we're not going to look at quality or anything like that. We're just going to look at rate. And so the question you want to ask yourself with respiration rate is the individual, by their breathing, are they creating an acid-base state, or are they responding to an acid-base state? If they're creating the acid-base state, what's happening is they might just be unloading or loading this side of the skull. So if we look at a patient that's hyperventilating, with hyperventilation, what's happening is they're blowing off CO2, and so they're taking the carbonic acid on this side, and they're blowing it off. And so in this case, what's taking place is they are actually creating that acid-base state. So I'm getting rid of carbon dioxide and H2O. So your patient might be anxious. They might be someone that has a closed head injury. And so again, they're unloading this side and they're creating respiratory alkalosis. On the other hand, you might have somebody that is breathing too slow. And so instead of tachypnic, they're actually have an extremely slow breathing rate. In that case, they're retaining on this side. So instead of breathing it off, that CO2 is retained as H2CO3, and then we're loading this side of the skull. A lot of times medications might be responsible for that. Either your opioids, your benzodiazepines, your barbiturates, alcohol, those are the kinds of things that can result in that. So again, respiration, you're thinking in terms of, am I creating the acid-base state, or I'm responding to? Because the other option is that I'm responding to an acid-base state. And so we might actually be either hyperventilating or hypoventilating in response to what's occurring over here. Now, we told you before that your bicarbonate is 1.4 milliequivalents per liter. Your carbonic acid is 1.4 milliequivalents per liter, and your bicarbonate is 24 milliequivalents per liter. So again, that 1:20 ratio. So before we talk about responding, let's look and see what the signal is for increased respiration. So back in physiology, you learned about the central and peripheral chemoreceptors. So if we look at the central chemoreceptors, what we have is the capillarization within the brain. And so we have serum or plasma here, and then we have CSF. So what's taking place is if we become hypercapnic, we're increasing the PCO2. That increase in PCO2, CO2 can diffuse into the cerebral spinal fluid, and it can join with H2O. Now, once that takes place, we're going to get H2CO3, and then that's going to disassociate into a hydrogen ion plus a bicarbonate ion. And so what that's going to do is that's actually going to drop the pH of the cerebral spinal fluid. Now, my normal pH of serum, if we look back over here, is the range is 7.35 to 7.45, being 7.4. So we've got 7.4 here, but what's happening under normal circumstances is that CSF is about 7.33. Now, the reason for that is because in here in plasma, we have protein buffers. In cerebral spinal fluid, we don't have those protein buffers, and so the pH is much lower. Now, once I liberate my hydrogen ion can act on respiration. So what I can do is as I increase hydrogen ion or decrease pH, both of those will result in increased respiration. So normally your body wants to maintain this range within a plus to minus 3 millimeters of mercury range. And so it tries to maintain that, and that is what maintains your normal breathing rate. However, if I were to bump this, say, to 7.45, what's going to happen is I'm going to see almost a doubling of my alveolar ventilation rate. The same thing, if I drop this serum or this cerebral spinal fluid pH, I'm going to see an increase in respiration as I'm trying to blow that off. Okay, so that's kind of what's controlling that at the central level. The peripheral, we're going to talk about later on when we talk about hypoxic drive and COPD. One thing to note is that an individual COPD has chronic hypercapnia, and what takes place is these medullary proteins actually downregulate. They don't respond to it anymore. And so if I have chronic hypercapnia, I've knocked out my central chemoreceptors, and only the glomerulus cell within the peripheral chemoreceptors are going to actually respond to the presence of oxygen or the lack thereof. All right, so let's look at what can happen if we're responding rather than primarily driving this. So we've got two different ways we can respond. We can respond over here with respiratory acidosis, or we can respond with respiratory alkalosis. And so in this case, what we're doing is we're going to compensate for something that took place over here. Now, we gave you the example back on the acid-base case study of the individual that was taking sodium bicarbonate. So as they took the sodium bicarbonate, they're producing more, releasing more hydrogen ion into the gastric lumen, and then they're also retaining that bicarbonate, plus they're absorbing the bicarbonate that they've been taking in. So what they've done is they kept loading this side of the scale, and they sent themselves into metabolic alkalosis. And so with the metabolic alkalosis, the response to that is you're going to start to hypoventilate. And that hypoventilate is going to cause respiratory acidosis as a response to that. So again, that's a different thing, because initially we said that we could create the acid-base imbalance, like if I have the opioid overdose and I have hypoventilation. But in this case, I'm creating respiratory acidosis in response to compensating for metabolic alkalosis. Okay, so another thing that we can do is we can actually respond to metabolic acidosis by going into respiratory alkalosis, and this would be a compensatory thing. So what I have over here is I have acetoacetic acid, and so with acetoacetic acid, this is a ketone, and so I wanted to show you what happens with DKA. So we've got diabetic ketoacidosis. So let's say that the individual hasn't taken their insulin, and so they're in this hyperglycemic state, but they don't have adequate insulin. Now, without adequate insulin, what happens is I can't get glucose into the cell. And if I can't get glucose in the cells think there's not glucose, and so they respond by releasing or producing these ketone bodies. Well, acetoacetic acid is a type of ketone body. And so now what I'm going to do is I have this acetoacetic acid that goes into blood, and it almost completely disassociates at a serum pH of 7.40. So what's taking place now is I have this molecule, and I am now having this situation where I have disassociated the hydrogen ion. All right, now I'm going to bring in my chemical buffers, because over here I have 24 milliequivalents per liter of bicarbonate. But what I'm going to do now is I'm going to take that bicarbonate and I'm going to join it with the hydrogen, and I'm going to form H2CO3. So here's what happened is I formed this H2CO3, I put it on this side of the scale, but to get it there, I had to unload this side of the scale. So right away, even just by unloading this side of the scale, I've taken it from the metabolic side, it's tipped to the acid side, so I've gone into metabolic acidosis. But now to compound things, I've actually added acid to this side. Now, if I don't do anything about this, you're going to continue to just completely drop the blood pH. But the response to adding it over here is that I've increased the serum H2CO3, which then is going to increase the amount of CO2 within the blood. I'm going to have more CO2 diffuse into here. I'm going to drop my pH, and I'm going to increase my hydrogen ion, and that's going to drive respiration. So now what I'm going to do is I'm going to start to become tachypnic. And that tachypnic is going to take these molecules that I've been loading on this side of carbonic acid, and I'm going to start getting rid of this. So anytime a patient is breathing fast, especially tachypnea up in the high 20s to even 30s, you have to think of it's probably not a primary, it's probably not but they're probably responding to something. And so you have to ask yourself, what is their respiratory rate responding to? And so diabetic ketoacidosis, it would be an example of that. We're going to look at, in another video, we're going to look at the response to sepsis. And so you really need to dial in to your patient's respiratory rate and ask yourselves the questions, what's causing the increase in this rate? All right, so now we're going to look at SaO2. So when we look at SaO2, we're going to put the pulse oximeter on the client's finger. And so we've got the oxyhemoglobin dissociation curve. And since we know that this curve, we can glean a lot of information from what that SaO2 is telling us. So for example, as long as if I'm at an atmospheric pressure of 760, okay, at 760 I have an FiO2 of 20.9%, And by the way, FiO2 is the same whether you're at an elevation of 7 or you're at sea level, or if you go up into the mountains. It's still going to be 20.9% oxygen in the air. So anyway, so I have this patient, they're at 760 millimeters of mercury, so they're at sea level. They have an FiO2 of 20.9. I also have to standardize their temperature, so we're going to standardize their temperature to 37 degrees Celsius, and we're going to standardize their serum pH to 7.4. If they've met these criteria, I know that if that pulse oximeter reads, so this is my SaO2 over here, if that pulse oximeter reads 100%, all right, that I can come across like this and down, and that their PaO2 is going to be at 100 millimeters of mercury, all right? I also know that if I have a patient and their SaO2 reads 90%, all right, as long as they're afebrile, they don't have an acid-base state, they're in normal range, their FiO2 is 20.9, and they're at sea level, I can come across like this and down, and I know that they're at 60 millimeters of mercury on their PaO2. Now, in physiology, you learn that when I'm looking at PaO2, it's a measure. A stands for arterial, but I can also look at PvO2, and that's venial. I know that red blood cells come back to the heart, and they've given up 25% of their oxygen. So if they're at 75%, I know, because of my hemoglobin oxygen disassociation curve, that they would have a PaO2 of 40. All right. So you can look at their SaO2 and glean from that what their PaO2 is doing. Now let's look at something, because we're going to confound that, because now I have a patient and they're febrile, so they have an increase in temperature, and they also, let's say they're going into acidosis, so they have a decrease in pH. Well, we know that these two things can shift our curve this direction. So now I've got the Bohr effect taking place because of the drop in pH, and then I have an increased temperature, which weakens the bond between the oxygen and the hemoglobin. And so that occurs normally in the body, because as red blood cells go by metabolically active tissues, they're going to give it more oxygen. But now I've got this patient, and I want to maintain them at let's say, SaO2 of 90%. Well, one thing to note is that most of our COPD patients, because they have residual carbon dioxide in the alveoli, they tend to live at SaO2s of 88 to 90%. And so I know that these patients, if they're afebrile and their pH is normal, they're right at about 60. But let's say I have a patient, they have COPD, but they're dropping down. And so they've dropped down to, let's say, 80%. So, and the reason they've dropped down is because they're febrile and they have this acidic state. So I also know that I can adjust it back up. So if I put a person on 1 liter nasal cannula oxygen, that's going to increase their oxygenation about 2 to 3%. All right? And so they should respond to that. So as I increase the percent of atmospheric oxygen, what's happening is in the alveoli, I'm increasing the P big AO2, which then should respond by increasing the P little AO2. So this is alveolar, this is arterial. And so as I increase the oxygen here by increasing the nasal cannula, I should increase it in this area also. So one other thing to look at is just what exactly is taking place in that situation. So if we were to look at 1 liter of blood, okay, so here I have 1 liter of blood. Within that liter of blood, I've got a red blood cell and I have plasma. Well, in plasma, if I have met these criteria of 760 and FiO2 of 20.9%, afebrile, and also normal pH, I know that I'm going to have about 3 milliliters of O2, mils per liter of O2 per liter, all right? And then within plasma, all right? I also know that if this is normal, I'm going to have about 197 milliliters of O2 per liter hooked to the red blood cell. So what this is showing me is the stuff that's dissolved in the plasma, that is your PaO2. So this is PaO2, and then this is your SaO2, all right? So per liter of blood under normal circumstances, we have about 200 milliliters of O2 per liter of blood. All right, so we go back to this patient. So they've dropped, let's say, from 90 to 80%. Now, what I'm going to try to do is I'm going to try to increase their SaO2. So Henry's law tells me that if I were to increase the partial pressure, so I increase the partial pressure of oxygen here, as I increase the partial pressure, I increase the diffusion into the plasma, and then I increase my PaO2. As I increase my PaO2 in here, what's going to take place is I'm going to increase my SaO2 on the red blood cell, so I should see that percent come back up. However, that's not always the case, because in some cases I can put them on oxygen by nasal cannula and I'm not seeing it come back up. I'm seeing it be refractory. If it's refractory, then something else is going on. What's happened is something is taking place within this diffusion or the respiratory membrane. Now, normally, when you look at the membrane, this membrane is about 0.5 to 1.5 micrometers thick. And so if that's still the case, then whenever I turn up their nasal cannula, what I should see is their SaO2 come up. If it's not coming up, something's happened to this membrane. And so we go back to Henry's law. Henry's law tells us that oxygen has a poor solubility coefficient. So if I start to load fluid into these spaces, because oxygen has a poor solubility coefficient, I'm not getting it diffusing across, which drops my PaO2, which in turn drops my SaO2. Since I have less oxygen dissolved, I have less oxygen loading on the hemoglobin. So anytime somebody's refractory to an increase in oxygen, you have to think about what's happening at this membrane right here. And so you could have pulmonary edema, you could have ALI, acute lung injury, or ARDS, acute respiratory distress, where what's taking place is you're actually getting infiltrate in here. And so now you're going to need to address that situation where either you have to diurese them if there's fluid, and that's what's causing the drop in SaO2, or in some cases with acute lung injury, you're actually getting eosinophils and neutrophils in here and actually getting almost impenetrable buildup of immunological cells in there. And so in that case, they might even have to be taken to ICU and mechanically ventilated if they're not responding to this. Okay, so, all right, so we looked at respiration, looking at rate. We looked at SaO2 in terms of determinants of SaO2. And then the final thing we're going to just mention is temperature. So with temperature, I might have two different patients, okay? And so I've got two different patients. One has a temperature of 103, and the other has a temperature of 103. Well, the question I ask myself is it pyrexic? Is it pyrogenic? Is it febrile? And so if a patient has a fever, that indicates something. Because I can have two patients with a temperature of 103 degrees, but only one of them has a fever. Because when you use the terminology fever, what you're indicating is that they are producing IL-1. And IL-1 is going to the hypothalamus and resetting the hypothalamic thermostat. Where IL-1 comes from is the macrophage. So out here I have this sentinel cell within the tissues, and macrophages, when they come in contact with pathogens and they form the phagosome and the phagolysosome, in response to the phagocytosis of the bacterium, one of the things they'll release is IL-1. IL-1 acts as a pyrogen, circulates the hypothalamus, or activates the arachidonic pathway, those COX-1, COX-2 enzymes, and it stimulates the synthesis of these prostaglandins. Prostaglandins will reset your hypothalamic thermostat, and that's why people get cold and start to shiver. And so that's what's going to bump their temperature up. Okay, so that would be fever. Now, pyrexia, in the absence of fever, or where something else is causing it, you have to think, okay, what things can cause this type of situation? Well, there's different things that can do it. Like, for example, if somebody has malignant hypothermia. And so with malignant hypothermia, what's taking place is you've got in the muscle cell, you have those RYR1 receptors that release calcium on the sarcoplasmic reticulum, and what's happened is they're malformed, and so what's taking place is some of your agents can cause blockage of this and cause the calcium to be released, and so they have this continuous contraction. Another thing can do it is thyrotoxicosis, and so with thyrotoxicosis, what's happening is that their basal metabolic rate is being driven by an excessive production of T3, T4. You might see that if somebody already has something like Graves' disease, and then they come into the hospital and there's a stress or a surgery, it might kick them into thyrotoxicosis, and so you're going to see this increase in temperature. All right, so that wraps up the review of vital signs. As far as some of the key things I just wanted you to consider when you're assessing a patient's vital signs.